Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast I'm joined by our deputy editor Nick Bostock.
Hiya.
And senior reporter Kimberley Hackett.
Hi everyone.
To look in detail at the government's 10-year plan for health and what it means for general practice. Coming up, we'll be looking at what the plan could mean for the future of the GP contract and the partnership model, the government's plans for a neighbourhood NHS, and what GPs think about the proposals. We'll also be looking at how the government plans to shift the NHS from analogue to digital and what this could mean for GPs and their teams. Meanwhile, our good news story this week is about the national rollout of a programme to train GPs with an extended role in gastroenterology. So it's been a busy couple of weeks with the publication of the government's 10-year health plan last week. We've basically been waiting for this since the government came into office just over a year ago. If you remember, shortly after the government came to power, it published the Darzi Review, which set out the problems in the NHS. The government said at the time that the NHS was broken, and the 10-year plan was going to set out how the government was going to fix it. That focus we already knew was on moving care out of hospitals and into the community, embracing digital technology and moving the NHS from a sickness first to a prevention model. Key to all of this is a move towards creating a neighbourhood NHS. So Nick, there's a lot to discuss, but I guess first things first, what does it say about general practice? Most people have seen that the government is proposing 2 new contracts, which it says could be alternatives to the GP contract. Can you explain exactly what it says about that?
I'll come on to those 2 contracts, but I think it's worth just running through a little bit of context first, just to give a sense of the problems the government says it's trying to solve with the ideas it's putting forward for the health service. For general practice, it talks about problems with access and says there's a need for more capacity. The plan says the government wants to end the 8 a.m. scramble, the rush to book appointments and contact practices first thing in the morning. And it says it wants to bring back the family doctor. So far, so good. It says part of the solution is more GPs. The government is promising to train thousands more GPs over the course of the 10-year plan. And the plan also talks about cutting bureaucracy and using tech, AI in particular, to try and save time for GPs. But then we come to what's probably the most important part of the plan for GPs, and the language it uses here is really important. It says that fundamental reform is needed to truly revitalise general practice, and that the, quote, status quo of small independent practices is struggling to deal with 21st century levels of population ageing and rising need. And it says that, quote, without economies of scale, many dedicated GPs are finding it difficult to cope with rising workloads. So according to this plan, GPs aren't struggling to cope because of long-term erosion of their funding. They aren't struggling to cope because practices can't afford to recruit the thousands of GPs who are currently struggling to find work. According to this plan, the problem is that they aren't working at scale. And that's where these new contracts come in. The 10-year plan says 2 new contracts will be rolled out from next year. One covering providers delivering enhanced services across what it calls a single neighbourhood. And the plan says a neighbourhood is basically the same as an average PCN, covering around 50,000 patients. And then there's a second form of large-scale contract for multi-neighbourhood providers, and that would involve all GP practices across a population of around 250,000 people, with shared back-office support, potentially taking on services like end-of-life care and with shared data and premises support, for example. And the plan bills these 2 new forms of contract as an alternative for GPs. It says that in areas where the traditional GP partnership model's working well, it should continue. And part of the outline of a multi-neighbourhood provider contract, these structures would support and mentor struggling practices within their patch. So that does suggest that individual practices could remain within or underneath these overarching large-scale contracts. But that also suggests that in some areas, existing partnerships might not continue. And it makes pretty clear that the government's view is that pushing GPs to work together across larger areas through a new model of care is the best way forward, rather than increasing support for the existing model of general practice. Another fundamental point in all of this is who could take on these contracts. The plan says existing PCNs could be a springboard for providers taking on single neighbourhood contracts. GP federations are also identified as an option. But it also says NHS trusts, so that's potentially hospitals, could take on these contracts. So just 10 months after a review the government commissioned from Lord Aradazi concluded that GP practices have the best financial discipline in the NHS and that problems in general practice were to do with capacity and not performance, because GP numbers had not grown and the profession was doing more work for a falling share of the NHS budget and from dilapidated premises. Just 10 months on from that, we have the government now opting for major change potentially rather than investment to address problems with the existing model.
The BMA had asked for a commitment to reform of the current GP contract to be mentioned in the 10-year plan. I mean, it was hoped that it would be. But apart from a very brief mention of plans to overhaul the Cahill formula to ensure it better reflects deprivation, there's not really any mention of the existing GP contract in there, is there?
Yeah, so the final piece of the jigsaw that got the 2025-26 GP contract for England over the line earlier this year was a commitment in writing from the government to work with the BMA on a substantive new GP contract within this Parliament. We've talked on the podcast before about what that could involve. It could build in safe working measures like a cap on patients per GP, as well as measures like a list of services practices are expected to provide that's fully costed and funded so that practices aren't continually swamped by rising demand with no extra money. I mean, to be clear, that's what the BMA would like it to involve. And the BMA said in the run-up to publication of the 10-year plan that it wanted an explicit commitment to this substantive new contract in the plan. And ultimately, it hasn't got that. As you mentioned, there's a line about Cahill. The plan says the government will review how health need is reflected in national contracts, including the Cahill formula for general practice. But although that formula, which is widely acknowledged as no longer fit for purpose and a factor that actually actively contributes to increasing health inequality, that's something that BMA absolutely wants to change, but it's only one small point on a long list of what it would like to see in a new contract. So the BMA will feel like it's being ignored on this. And I think particularly given what the 10-year plan says about dentistry, that's the case. For dentists, the plan specifically mentions a short-term plan to improve the dental contract and how that might work, as well as plans to start what it calls a more fundamental contract reform. Similar wording for GPs would have been very welcome, but that hasn't materialised.
Have we heard what the BMA GP committee thinks about all this, about those new contracts, about the lack of mention of a big overhaul of the GP contract? What have they had to say about this?
I finally got a response from the BMA GP committee about 5 days after the report was published. That's fairly telling in itself. Part of the response made clear that the BMA's GP leaders hadn't been given a chance to look at or contribute to the plan in advance of its publication, not beyond the public consultation phase in any case. Given how much the plan has to say about general practice, that doesn't exactly fill you with a sense that this is a government keen to work hand in hand with GP leaders on shaping the profession's future. But it also meant much of this stuff about new contracts will have come as a surprise to the BMA, even if the sense of the government being keen to shift to doing more at scale will not have surprised them at all. And the BMA said it was working through the plan to put together many questions that it has for government. The BMA was obviously disappointed about the failure to get the explicit contract promise that it wanted, and the GP committee told me that it needed detail and funding to support the new contract that they've been promised. But there's a bigger concern in all of this for the BMA GP committee. They said that the plan points to potentially profound changes to general practice that could seriously undermine the current practice model and the continuity of care that patients rely on. So they're worried about the erosion of the current contract, the impact that a move to deliver services at scale will have on the relationship between GPs and patients. There's lots of evidence, obviously, of the benefits of continuity of care. But if patients increasingly receive care in other locations, such as neighbourhood health centres rather than their own GP practice, what does that mean for continuity? And the other point the GP committee response flagged was the fact that despite a promise to train thousands more GPs, there's nothing in the plan about how the government's going to create jobs for thousands of qualified GPs who already can't find work in the NHS.
Yeah, it's interesting, that point on continuity, actually. That's something that came up in the think tank, the King's Fund response to the 10-year plan. They were talking about the fact that the plan is quite big on continuity for people with complex health needs, with long-term conditions. It doesn't really mention anything about continuity for all patients when there is evidence that that is kind of what we would get the biggest benefits from if everybody had access to continuity. So it's going to be interesting how that all plays out. The other thing the plan mentions is these new organisations called integrated health organisations, which most people will have no idea what they are. What exactly are they? What are they going to be doing? How will general practice fit in with that?
This is potentially a really radical change to the way NHS funding works. And it's based on much more devolution of control to provider organisations. The 10-year plan talks about reinventing and reinvigorating the NHS Foundation Trust model. It says that high-performing foundation trusts will be offered the chance to take control of the whole health budget for a local population as an integrated health organisation. The first trusts could potentially be awarded these powers from 2026, and then they could become operational from as soon as 2027. The standard criticism levelled at any plans to create devolved organisations with this kind of level of control over budgets and so on is that it looks like setting up the NHS for privatisation. And the plan covers that by saying that there'll always and only ever be NHS organisations. Although it does say too that they'll be able to contract with other service providers within and outside the NHS. In terms of what they'll be expected to do, the plan says they'll be required to support integration, move resources out of hospital into the community, focus on population health and tackling health inequality. It actually only mentions foundation trusts, so generally hospitals forming these integrated health organisations. But there is also a suggestion that successful GP providers could run hospitals as well. That's something that Wes Streeting mentioned a little while ago in a speech at an NHS Confederation conference. One criticism of this proposal that came from a GP I spoke to was around which trusts were most likely to be the ones that are high performing. His point was that struggling trusts, like struggling practices, are generally found in areas of deprivation. So on that basis, we could see fewer trusts or GP-led initiatives potentially in areas that perhaps most need a new approach actually being granted those powers.
What does all this mean, do you think? Will hospitals be taking over practices? Is it the end of the partnership model? Does all of this make the BMA's job much harder when it comes to negotiating a new GP contract?
In terms of whether hospitals will be taking over practices, that's something the BMA is definitely worried about, I think it's fair to say. One of the defining features of the NHS is this sort of power imbalance in favour of hospital trust versus general practice and primary care. The sense that hospitals always have a louder voice, more funding, even though they often need massive financial bailouts that aren't an option for GP practices. And that power comes with their size and the fact that these new neighbourhood contracts are open to hospital trusts, as well as the prospect of them potentially taking control of the entire health budget for their region as integrated health organisations, means there are clear avenues for hospitals to have control over general practice at the very least. Calling neighbourhood contracts an alternative to the existing GP contract also kind of suggests that in some areas takeovers or mergers could happen. Just before the 10-year plan came out, the BMA said GP practices were facing a critical choice. It was either step up and form provider collaborative organisations, prepare to take on and lead services at scale, or risk hospitals and other NHS organisations like community trusts becoming the default option to lead neighbourhood services. There's definitely a concern that hospitals could be lining up for the sort of power grab, and there's also reason to be concerned about the partnership model. It's worth saying here that NHS England said before the plan was out that it would protect the partnership model, and the plan does say that where the partnership model is working, it should continue. But coming back to that BMA warning about practices needing to step up and take the lead on neighbourhoods and services at scale, it also said that if practices couldn't do that, then individual practice contracts could feel increasingly marginalised, and that there could be a risk they'd be pushed into vertical integration with hospitals or other types of trust. Ultimately, though, the future of the partnership model probably depends most on the government's willingness to fund it. And given the lack of commitment on that in the 10-year plan, the BMA really has its work cut out now when it comes to negotiating a big new contract. And some GPs I've spoken to say that they absolutely think the job of negotiating that contract's become a lot tougher, a lot more complicated in the wake of this plan.
All of this in the plan is to help the government deliver on its proposals for a neighbourhood NHS. This week, the government announced it will be launching neighbourhood health in a number of areas from September. What do we know about that?
Just under a week on from the publication of the plan itself, the government announced that it had written to local NHS leaders and local authorities, inviting them to bid to be part of the first wave of a neighbourhood health service programme. And the government said 42 sites will be chosen. Deprived areas are going to be prioritised initially, and the rollout of this model could start from September. The whole idea is absolutely central to government plans to move care out of hospitals into the community. According to the 10-year plan, the core principle behind the neighbourhood health service is that care should happen as locally as it can, digitally by default, at home if possible, in local centres or hospitals if necessary. So services work more closely together in local areas to make that happen, across health, social care, mental health services, voluntary and community care. And the idea is that this should reduce the amount of acute emergency and outpatient hospital space the NHS needs and enable the shift of funding to the community. I think you mentioned the King's Fund, and they and other think tanks have raised some concerns about just how likely it really is that money is going to be freed up in any kind of immediate way by these plans.
The King's Fund also said it's not necessarily cheaper to do this in the community, and certainly not in the short term. And I think there's a lot of assumptions in that plan that it will be cheaper. The other thing the plan obviously talks about, and we've heard about these for a while now, is these new neighbourhood health centres that are going to be set up. What do we know about them? How many are we getting? Where are they going?
Whereas the idea of a neighbourhood health service is effectively collaboration across an area between organisations and community providers of different types, neighbourhood health centres are physical buildings that the government plans to develop as part of the neighbourhood agenda. They're described as a one-stop shop for patient care, and they'd be a sort of hub for a multidisciplinary team. But it's a team that goes way beyond the current primary care concept of a multidisciplinary team. The idea is that these new facilities would house NHS staff alongside local authority and voluntary sector services, things like diagnostics, but also services such as debt advice, employment support, smoking cessation services. And these places would be open at least 12 hours a day, 6 days a week. They could be set up in refurbished existing NHS premises or potentially in new buildings. As with neighbourhood services generally, the plan is to start in deprived areas first, and the government said there could be up to 50 of these centres in place by the end of the current Parliament and up to 300 by 2035. But I think with all of this, the problem is that there's a real lack of detail. Keir Starmer's introduction to the 10-year plan said that neighbourhood health centres will be available in every community. But what's a community exactly? It's clearly not the same thing as a neighbourhood, because the plan describes neighbourhoods as basically fitting existing PCN footprints, which cover about 50,000 people on average, and there are about 1,250 PCNs. So if there are only a maximum of 300 neighbourhood health centres by 2035, only a quarter of PCNs are actually going to have one, even a decade from now. And who's going to staff them? There's the promise of GP services and other health or social services in neighbourhood health centres, but are they walk-in? Would they have a registered list? Could existing practices move in? At this stage, we just don't know. If you're being optimistic, maybe that's the kind of thing that proactive GPs can shape as they see fit. And we know also that in some areas, GP practices, along with other organisations, are already working in the kind of way that the government's talking about.
Yeah, exactly. And that's where they launched this 10-year plan, isn't it? Is a health centre in East London, which is already doing all the things that they want people to be doing. The government has said it will look at public-private partnerships to build these centres. Do we have any sense about how that will work?
Yeah, so the government's already exploring public-private partnership funding for this. A notice went out inviting interested organisations to come forward just a week or so ago. The BMA is very wary of funding developments in this way because of problems in the past with public-private partnerships under the last Labour government, which left hospitals with legacies of heavy costs. Those deals proved hugely expensive. And given the fact that building costs have risen significantly over the past decade or so, And I think particularly since COVID, the cost of these public-private deals could be really significant. So as a benchmark, in 2017, developers put forward an offer to the government to invest £3.3 billion to build 750 new health centres in return for a guaranteed return of £200 million a year. In today's prices, presumably, that would cost a lot more. And whether this is the right use of funding when a fifth of GP practices, so existing GP practices, before you even start investing in these neighbourhood health centres, a fifth of existing GP practices predate the NHS. Some use sticky tape to cover holes in their windows, according to surveys from, I think, the RCGP not so long ago. And thousands of GPs are unemployed because practices can't afford to recruit. So is it the right use of money in those circumstances? I mean, that's a really fundamental question about all of this.
So Kimberley, let's bring you in here. You've been speaking to lots of GPs over the past few days, GPs on the ground who are GP partners, clinical directors, and it's fair to say views are fairly mixed, aren't they? Some seem quite positive about all this, don't they? What do they think is good about the 10-year health plan?
So actually, most of the GPs that I have spoken to are generally quite positive about the plan's vision. They're all on board with the 3 shifts and like that the plan identifies problems specifically in general practice and across primary care and the community. One PCN clinical director told me that it's positive to have care closer to home. She was also really pleased with the digital aspects of the plan, the add-ons to the NHS app, such as booking appointments and the care plans, and she liked the introduction of single patient records. Another GP told me that PCNs in his area, along with the provider collaborative, have actually been having discussions for the last 2 years about how they can work together to become more of an entity. For them, the plan has confirmed that their ambitions were actually heading in the right direction, and they said they now have the momentum to move forward, and they have now started talking about the multi-neighbourhood provider contract. But he did also say that it's important that GPs are at the forefront of these contracts and neighbourhood health services. In fact, 3 GPs I spoke to said that their PCNs, along with other local providers, have already had discussions about the 2 10-year plan contracts and are looking forward to seeing them in more detail when they come out. And GPs also said they were happy to see the focus on prevention, which is one of the 3 key shifts. And one PCN said they are already planning to have lots of meetings with public health to look at the next steps to take.
Yeah, but we've also heard from people who are less enthusiastic. What have they been saying that they're concerned about?
So the list of concerns is a little longer than the positives, but as I said earlier on, most of the GPs I spoke to are on board with the plan's vision. But the problem is that many of them are concerned that it is just a vision rather than an actual plan. One PCN clinical director said to me that he thinks it reads more like a manifesto and lacks clear guidelines of how things should be done and by when. He suggested that the plan should have included timelines as to when the government expects certain elements of the plan to be introduced. Another GP told me they were concerned by the lack of plans around premises and where the workforce will be housed when neighbourhood working really kicks in. She said that her PCN has already been doing some neighbourhood work since 2019 and space has always been an issue. While this GP did back going digital, she, like many others, are worried about the very real possibility of some people being left behind who are not digitally savvy or don't have access to digital tools. And another issue that came up a few times was around neighbourhood footprints. One GP said it could be one of the biggest challenges. So aligning patients geographically, especially when practices are always being told that patient choice is something that has to be taken into consideration, could become a bit of a logistical nightmare for practices. Now, while GPs are on board with moving care out of hospitals into the community, a few GPs told me that there was actually some anxiety around this shift because the plan hasn't come with any extra funding or staff to support this change. In fact, concerns over a lack of funding for the plan's entire vision came up a lot, as some GPs felt there was simply not enough money for it to be fully executed. And a newly qualified GP and a GP registrar, who is set to CCT in September, said that they don't feel that the plan really goes far enough to address the GP underemployment and unemployment crisis, although we know that there will be a workforce plan being released in the coming months. So perhaps this will address people's concerns then.
So, Emma, there's obviously a lot in the plan about technology and AI, isn't there? This shift from analogue to digital. What could all that mean for general practice?
Yeah, I seem to end up writing all the stuff about tech. I've obviously become our new AI correspondent. But yes, obviously analogue to digital is a big push for the government, and AI inevitably is going to play a big role in all of this. The plan actually says the government wants the NHS to be the most artificial intelligence enabled care system in the world. So it's not thinking small on this front at all, really. I guess the immediate development practices we'll see in the next couple of years will be AI scribes. The plan mentions them quite a few times, and lots of practices are actually using these systems already. You know, it is possible we could see other AI technology in general practice pretty quickly as well, because developments are moving so fast in this space that something we don't even know about now could be the big new thing in a year's time. In recent weeks, we've seen warnings from the BMA and RCGP and the NHS's Chief Clinical Information Officer about the use of these AI scribes, and concerns that maybe some of the systems being used in both hospital trusts and practices might not meet the standards that they need to. NHS England put out some guidance about their use a month or so ago, but I think that left some people with more questions than answers about what approval these systems need to have. And this is where a lot of the problems lie with this new tech. This stuff is coming on stream so quickly that it's not clear whether the regulations and rules within the NHS are keeping pace with the tech. And the BMA and RCGP are concerned that practices and GPs could unwittingly find that they're not complying with specific regulation. You know, and that's a big area of risk, particularly when it comes to patient data. So the 10-year plan could address some of this, because it says the government will accelerate the adoption of AI by streamlining regulation. A new national procurement platform will be set up during 2026 and 2027 to support practices and hospitals to adopt new technology safely. You know, probably we need that sooner rather than later, though, for these AI scribes, because, as I say, lots of people are using them already. Certainly, it needs to be much easier for practices to tell whether the systems they are using comply with the rules that they need to. I think there's also a really big question about funding for all of this new technology as well. Practices are paying for some of these things themselves, and I think the BMA would definitely like to see money available for new technology if the government really wants practices to make use of it.
The NHS app's really at the heart of the government's plans for this technology revolution, isn't it? Wes Streeting described it as becoming like a doctor in your pocket, didn't he?
Yeah, massive change to that. I mean, basically, the government wants it to be as easy for patients to interact with the NHS via their phone as it is to do online banking. I think we've heard that quite a lot over the years, haven't we? So massive overhaul of functionality in the app, with new features coming on stream in every year of the next 10 years, the plan says. You know, eventually, Kimberley's touched on this, eventually people will be able to book appointments, rate all providers, have consultations, communicate directly with their specialist or GP, make decisions about where to have their treatment, access all their health information and their child's health information, all via the app. There's going to be a new function called My NHS GP, which is going to use AI algorithms to help patients with non-urgent care needs. So that's going to give them self-care advice or direct them to where they can get help. That will apparently be available by 2028, by which point the 10-year plan says that the NHS app will be the front door to the entire NHS. Underpinning all of this is something that Kimberley also touched on earlier, will be a single patient record that patients will have access to in the app. They'll be able to add their own data to this via wearable technology. It will become a legal requirement for all NHS providers to share data for that record, and legislation will say that patients will have access to that record by default. Eventually, that record will include all sorts of information, including genomic and demographic data. It will provide clinicians and patients with details about their risk of developing disease, and clinicians with evidence-based information specific to that patient about management plans and treatment options. And, you know, genomics is a really big focus of the tech developments in the plan. There's basically what the plan calls 5 big bets the government is making on technology to help improve the NHS, which are AI, obviously, better use of data, genomics and predictive analysis to help personalise care, wearable tech, and robotics in surgery. That last one's probably less relevant to general practice than the other 4.
This all sounds very ambitious.
It is. There is huge amounts riding on really, really cutting edge technology to improve productivity and to improve people's health. We mentioned a few weeks ago when we were talking about the spending review that all of the government's calculations in terms of funding for the NHS are based on the assumption that the health service can improve productivity by 2% every year. And this plan makes clear that mostly they're hoping to gain that productivity through new technology. As a result of all that, the 10-year plan says that the NHS workforce won't need to grow as fast as currently predicted over the next 10 years. Kimberley mentioned a new 10-year workforce plan that's going to be published in the autumn, apparently, and that's going to predict a much smaller growth in the NHS workforce by 2035 than the current plan, which was developed under the previous Conservative government. There are obviously huge efficiencies to be gained from AI and tech, but whether it's at the level that is predicted, that's a massive question. For example, the plan says that making use of AI scribes in general practice could save 90 seconds on each appointment and will generate over 2,000 full-time equivalent worth of GP capacity. But it's not going to create that capacity, is it? Practices are not going to be making appointments 90 seconds shorter. It just means that GPs will have an extra 90 seconds with those patients to spend proper time with them and engage with them without having to be typing on a computer. That's not a realistic analysis of what that technology will help achieve. It will help make GPs' lives easier and might make consultations better and might mean that GPs get to go home on time or at least a bit earlier, but it's not going to create 2,000 GPs. All this talk about AI is great, but most GPs and other NHS staff would just like to have a computer that doesn't take ages to boot up in the morning. So you've kind of got to get the basics right as well. And I think there will be big challenges with a single patient record as well. Everyone accepts that it isn't great when very poorly people have to explain their story over and over again to different parts of the NHS. But I think privacy campaigners will have concerns about this and GPs as well. Dr. Katie Bramwell, the chair of the BMA GP committee in England, said this week that they would want to have significant discussions with the government about the use of confidential patient data. GPs are currently the data controller for this information, and the BMA says it wants solutions around indemnity to protect practices if any data breaches happen as a result of these government policies. That's potentially a big issue which could come up. And I think there's also going to be big question marks from some quarters about a massive US company potentially being responsible for it if that's what happens. Palantir are currently running the NHS Federated Data Platform. Will they be doing this as well? And one final thing, the NHS app could be a good way to deliver some of the tech benefits directly for patients, but the government's going to have to be really careful about digital exclusion. We need to make sure we don't entrench existing inequalities by using this tech or build in more biases into the system. A lot of AI tech is biased because it's based on the information that goes into it. And that information itself is biased for all sorts of reasons. And at the end of the day, healthcare isn't online banking. It will be more convenient for some people to do things digitally, but fundamentally, when people or their family members are unwell, they will want to talk to someone about it. We can see that with the constant discussion about face-to-face appointments in general practice, which hasn't gone away, even though practices are delivering record numbers of appointments. And I'm not convinced because of that this technology will save as many appointments or as much money as the government says it will, or whether patients will embrace it enthusiastically as the government hopes.
One of the GPs I've spoken to in the past week or so following the publication of the plan raised exactly that point you made about whether going big on tech is going to work in the kind of areas that the government says it wants to target first. Deprived areas are potentially those with the highest rates of digital exclusion, and therefore the idea of leaning really hard on tech to improve care may not work in those areas, just as, like he pointed out, the likelihood of the top performing trusts being in those deprived areas is also lower. There's a fear that some of these big plans may not actually work in the areas that the government says it most wants to target them at. Coming back to the broader point, what do you think the whole plan means for general practice and the NHS as a whole?
It's difficult to tell, isn't it? But I think before we finish on all this, I think it's worth mentioning, we seem to have focused a lot on the negatives, but there's a lot of positives in the plan, and people I've spoken to have really welcomed a lot of it. Lots of commentators have also mentioned the positives in there. You know, it's clearly the right direction of travel. There's lots of things in the plan that aren't new and that will be familiar from previous governments and previous discussions and previous reports. But, you know, as the King's Fund pointed out, that's not necessarily a bad thing. But I think the problem is there's some massive question marks over how we actually get to that end point and what the detail is about delivering this. There just isn't any detail on how we're going to do all this stuff. You know, without seeing those new contracts, it's quite difficult to really tell what they mean for the future of the partnership model. Without knowing what's in the new GP contract and what funding comes with it, it's also quite difficult to tell what the future holds for general practice. So there's a lot we're going to need to keep our eye out for as time goes on. And also, obviously, we've seen the announcement this week of a 5-day strike by resident doctors at the end of the month. The BMA is also holding indicative ballots on the appetite for strike action among consultants and SAS doctors. That could really derail progress on getting the waiting list down. And if that happens, really, that could become a much bigger immediate priority for the government than some of the changes set out in this plan. So there's a lot of questions that the government still needs to answer on how it's going to deliver on all of this. Before we go, just got time for our good news story, which this week is about GPs with extended roles, isn't it, Kimberley?
Yes, a programme that started its trial 2 years ago to train GPs with extended roles in gastroenterology has been approved for a national rollout across England, and NHS England has awarded the programme £552,000 to train 16 GPs across the country. How it works is that GPs are trained to work at the interface between primary and secondary care, and the GPs are provided with an online education, plus clinical training and experience in hospitals, including ongoing clinical supervision from consultants. The rollout has been made possible because an analysis of the trial found that the cost of training the GPs was more than offset by the reduction in hospital-based activity. So the cost of training a GP was £23,000, but the evaluation found that this would reduce to £17,000 once the scheme was rolled out nationally.
I actually did an interview with the GP who set up that initial programme, Dr. Charlie Andrews, for the podcast in March this year. So if you want to find out more about what that training scheme involves and how it could help the NHS develop new roles at the interface between primary and secondary care, do have a listen to that episode. Well, that's it for this week. Thanks to Nick and Kimberley, and thank you for listening. I'll be back next week when I'm speaking to GP Dr. Duncan Gooch, who's the chair of the NHS Confederation's Primary Care Network, about his views of the 10-year plan and how he thinks general practice will change in the coming years. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news on our website at GPonline.com.